Hello everyone, I think most of you know me now, but my name is Risa. I've been a critical care nurse for over 10 years and I'm working on my doctorate of nursing practice, which I hope to graduate with in May. Today we're going to talk about opiate overdose and naloxone. I want to thank you all for watching and being willing to participate in our pilot and learn today. This has been a cool project for me. I want you to know that your participation makes a difference. There's very little published literature that addresses the experience and outcomes of rural volunteer EMTs, and you're part of creating that representation. The big goals are to recognize signs and symptoms of opiate overdose, initiate appropriate treatment and interventions to prevent cardiac arrest, and explain the rationale for administering naloxone to reduce fatalities due to opiate overdoses. If you are doing the case study, it will be to demonstrate support of respirations and administration of intranasal naloxone. If you're just watching the video, you will not get that. So right now, do you feel confident about treating opiate overdose? If so, that's fantastic. We will build on your skills tonight and teach you a few new things. I want this to be value-added time for everyone, so I'd encourage you to email questions and let me know if anything is confusing. Opiate overdose kills by suppressing the respiratory drive, leading to low oxygen and high carbon dioxide levels in the body. In national and Montana state data, EMS providers gave naloxone about 50% of the time when it was indicated, and gave it when it was not indicated in about 50% of cases. These statistics include paramedic data, and actually smaller studies found that EMTs were more likely to give naloxone when it was indicated than paramedics. But the reality is that we're likely missing an easily reversible process that can cause death. It's especially important for all of you to be well trained to reverse opiate overdose, because although most overdoses occur in urban areas, rural opiate overdoses are more lethal. The higher death rates in rural areas are likely related to care delays due to fewer EMS resources and longer response times. While some urban EMS services report that they make first patient contact within 8 to 10 minutes of a call, rural EMS services, like Three Forks, average around 20 minutes. Opiate overdose deaths are increasing in Montana and remain high nationally. Synthetic opiate overdose deaths are increasing and now account for over half of Montana opiate overdose deaths. Identifying opiate overdose may seem simple, but the reality is that opiate overdose complicated by the use of additional substances like alcohol or benzodiazepines, or medical comorbidities like heart disease or COPD are more common than single substance opiate overdoses. Opiates have a high potential for abuse, but have an accepted medical use in patient treatment and can be prescribed by a healthcare provider. Legally prescribed opiates include cocaine, fentanyl, hydrocodone, morphine, hydromorphone, methadone, morphine, oxycodone, and oxymorphone. Opiate derivatives such as heroin are illegal in the U.S. Synthetic opiates are just opiates that are manufactured in a lab instead of being derived from the poppy plant, like morphine. These are becoming much more common in the drug supply and are harder to detect on laboratory testing done by healthcare providers and law enforcement laboratories. High-potency synthetic opiates, also called fentanyl analogs, have received a lot of press lately. High-potency opiates are hundreds to thousands of times more potent, stronger, than morphine. They are more lethal in opiate overdose, especially when they're sold to lower-potency opiate users who are more used to the potency of heroin, morphine, or prescription pills like hydrocodone and tramadol. Often heroin is cut with high-potency opiates to stretch it, which puts users at higher risk for opiate overdose. Legally prescribed fentanyl has many formulations. One of them being a delayed release transdermal patch, as you can see on your slides. If you see one of them, the recommendation is to remove it and bring it with you and the patient to the hospital. If you double glove, you can remove it with the glove and wrap it in that glove and take it with you and the patient to the hospital so that they can help identify it there. These patches last 3 days, and some of the writing wears off easily, so they're not always easily identifiable and differentiable from a nicotine patch. Some opiates have additional toxic effects. Methadone can produce QT prolongation, and tramadol can produce seizures. You do not need to remember which of these drugs have additional toxic effects, and I recommend you do not. When law enforcement laboratories test samples of the drug supply, they often find that the drugs do not contain what the user thinks they bought. So if your patient is using illicit drugs, the illicit drug supply often contains additives that can have serious cardiac and neurological effects. And the only way to know what is in that drug is to send it to a forensic laboratory. Even methadone, which is a legally prescribed long-acting opioid, can cause EKG abnormalities that can lead to lethal arrhythmias in large doses. This is why these patients deserve an EKG at some point, either from you or the ER. Neither you or they may actually know what they took. Some opiates are manufactured as combinations of analgesics with Tylenol, aspirin, or other substances. In the scenario of an overdose of combination opiates, there is a potential for multiple drug toxicities. Both acetaminophen and aspirin can be lethal in overdose. These medications can cause liver and kidney failure. Naloxone has only been recently added to the EMT scope to decrease opiate overdose deaths, but has been used for 40 plus years to reverse opiate overdose by paramedics in emergency rooms. It has been well studied, it's safe, effective, and specific to opiate overdose. It is not a DEA scheduled medication. It is available over the counter in many states. It has no mind-altering effects and no purpose other than the reversal of opioid overdose. Therefore, it also has no abuse potential. In fact, most daily users of opioids will not feel well when given the medication because they are dependent on opiates. Naloxone reverses opiate overdose by pushing opiates off of their receptors, restoring the respiratory drive, and preventing any more opiates from binding during the action of the medication. It will reverse the somnolence seen in opiate overdose. In daily opiate users, it can precipitate withdrawal. Naloxone is proven safe and effective at reversing opiate overdose. However, it has a shorter half-life than most opiates. Critically, the length of time that volunteer EMTs treat patients in Montana routinely exceeds the length of naloxone's effect, putting patients at risk for rebound respiratory depression. Naloxone can take 5 to 10 minutes to take effect. This is especially true when you're using intranasal naloxone, like we use. Intranasal naloxone must be absorbed through the nasal mucosa. Hence, it requires cardiac effort to be able to pump the blood into the mucous membranes and return the blood carrying the drug into the systemic circulation, or the heart. So it can take longer for patients who are not breathing well and haven't been for a while. So how could you help support your patients use the naloxone you squirted up their nose? You can help them by supporting their airway, breathing, and circulation first. Before giving naloxone, support the ABCs, just like you would with any other situation. For all patients, naloxone's effect commonly lasts 30 minutes to 1.5 hours. Considering your transport times, an average of 50 minutes of patient contact time with a 20-minute response time, That means that the naloxone you administered when you first got to the patient, or a layperson or law enforcement officer administered before you arrived, could easily wear off before you reach the ER. What should you do to make sure you don't miss your patient's rebound respiratory depression? So on the slide, pulse oxygen and end-tidal CO2 for continuous respiratory rate monitoring. We as healthcare providers are not good at counting respiratory rates. It's because it takes a long time. We're impatient. We don't like to sit there and stare at a person, and it's hard to do. So I recommend you outsource that to a piece of equipment to help you with that situation. Your end-tidal CO2 monitor has a continuous respiratory rate on it. If you put that on your patient, you will know when their respiratory rate drops. Which one of these signs are you going to see become abnormal first? Well, the first thing to drop is going to be the patient's respiratory rate. Their oxygen is usually just dependent on their respiratory rate unless they have some other process going on, which, as we previously discussed, is common. Remember, multifactorial overdoses that are combined substances, or a patient has a comorbidity are more common than single substance opiate overdoses. You are all using intranasal naloxone, and that's the route that is recommended for EMTs. For the record, that's not because you're not skilled enough to give naloxone by other routes. It's because you're usually the first providers on scene, and intranasal naloxone is fast. You don't have to start an IV or draw medication up. You can just give it. It's always the first route recommended, if available, by the American Heart Association for this reason. You may have noticed that the dosage you give intranasally is much higher than the dosage recommended IM or IV. That's because only about 40% of the medication you give intranasally is absorbed and able to work, pushing opiates off of their receptors. As we talked about previously, naloxone, and especially intranasal naloxone, will not work as well in a patient who is not pumping blood well or is so acidotic that they are clamped down. Both of these patient problems are related to the patient not breathing and pumping blood well for too long. So step one is to always support your ABCs. You know you will not get ROSC without good CPR. Similarly, you will not get a good naloxone response without supporting the ABCs up to and including CPR if indicated. There have been instances where EMTs have just had to perform rescue breathing until the patient is able to get IV naloxone from the paramedics. But this is very rare. Typically, intranasal naloxone works if you give it enough time and you support your patient adequately. Causing precipitated withdrawal by giving naloxone is a fear of most clinicians. Patients may become agitated or violent following naloxone administration due to acute opiate withdrawal. Therefore, the goal is to use the lowest possible dose to restore spontaneous respirations but avoid precipitating withdrawal. Precipitated withdrawal and serious side effects are more likely with higher doses. So remember, it can take 10 minutes for naloxone to take effect and support the ABCs while you're waiting to see if your naloxone dose was effective. Remember, people who do not breathe can also have altered mentation and respiratory drive. Think COPD exacerbation. So you may have to reverse their breathing problems to see naloxone effect, especially if they have not been breathing well for a while. Again, serious side effects of naloxone are rare, but seizure and life-threatening arrhythmia have been reported, primarily when very large doses of naloxone have been given. Lastly, keep yourself safe. If you have any concerns, request law enforcement assistance. So you may be thinking, all of that is great information, but how do I actually give the naloxone, and how do I decide who to give it to? Well, we're going to go over the protocol for that. Scene safety considerations include PPE and situational awareness. Gloves are always needed. Patients who inject substances have a higher risk for bloodborne pathogen exposure, making needle stick injury a higher risk for EMS. Expect needles in the environment and be on the lookout for them. Do not reach anywhere that you can't see. In rare cases of known large quantities of powdered, aerosolized, or liquid high-potency synthetic opioids, take appropriate precautions, including eye protection, face masks, gowns, or suits, if needed. I will tell you that as an ICU nurse, I've handled large quantities of liquid fentanyl and Dilaudid for years without dosing myself, and I have spilled it on my bare skin many times. The literature contains a few case reports, primarily of powdered fentanyl analog inhalations by law enforcement officers, but this is exceedingly rare. Primarily, the risk is from needle stick injury, not the drugs themselves. So the signs most predictive of opiate overdose are history or suspicion of drug overdose, including paraphernalia like syringes and pills, unresponsiveness, myotic or pinpoint pupils, and respiratory depression. Respiratory depression or arrest may progress to cardiac arrest. Therefore, patients in cardiac arrest may also be administered naloxone. Basic life support intervention should be initiated using the cardiac arrest protocol. Isolated altered mentation without respiratory depression or pinpoint pupils and neurological deficits are rarely associated with opioid overdose. Patients with altered mentation known to be exclusively from other causes, such as head injury or hypoglycemia, should not be administered naloxone. So what does this look like in practice? Patients who die from opioid overdose die from respiratory depression, leading to cardiac arrest. So if your patient's biggest problem is ventilation, give naloxone. If they're not breathing well and there is evidence of opioid overdose, give naloxone. If they have pinpoint pupils and are not breathing well, give naloxone. If they're just altered and breathing fine, don't give naloxone. So why would you think that we wouldn't give naloxone to everyone if, it doesn't do anything if we don't have opiates on board? Well, the minute you give that person naloxone, if they later need pain control, while that naloxone is on board, no opiate pain medication will work for that patient. So that's something to be aware of. That could be up to an hour and a half. Also, patients who use opiates for legitimate reasons, such as, chronic pain or even acute pain, you are going to reverse their opiates instantly, and you may make a bad situation worse by putting a patient into withdrawal who had some other process going on that had them call you in the first place. So don't just reverse people without a good cause. First, assess and support airway, breathing, circulation, disability, and exposure. Ensure a patent airway, use airway adjuncts, and support ventilation and oxygenation as needed. If the patient does not have a pulse, initiate CPR before giving naloxone, or as you give it, initiate CPR in a multiple rescuer situation. Assess the patients for signs of opiate overdose. If the patient is hypoventilating from confirmed or suspected opiate overdose, give naloxone. Remember, the clinical effect takes an average of 10 minutes, so continue to support the patient. You may not see an immediate effect, especially if the patient has not been breathing well for some time. Partial effects and rebound respiratory depression can occur. Continue to support the patient's ABCs. Document naloxone response using AVPU or GPS and respiratory rate at a minimum. Apply cardiac monitoring. pulse oximetry, and end-tidal CO2 if you can. If the naloxone response is incomplete, assess for other etiologies. Remember, most overdoses are multifactorial. Check blood glucose and treat it if less than 60 with IM glucagon. Titrate oxygen flow to maintain an oxygen level of at least 94%. Measure a blood pressure. Consider if the patient could have a head injury. Apply end-tidal CO2 to measure respiratory rate, adequacy, and airway patency if an advanced airway is in place. If possible, get an EKG to assess for other causes or sequelae of opiate overdose. A partial response can look like a patient who gasps, opens their eyes, and then goes back out. It can also look like a patient who is now breathing better, deeper, and faster, but still requires oxygen to maintain saturation. They're responsive to verbal stimuli, but may be sleepy and disoriented. Some of these patients may need another dose after supporting ventilation and oxygenation, especially those who have been exposed to high-potency opioids. However, more commonly, these patients have multifactorial overdoses and have comorbidities or other substances on board. A patient with rebound respiratory depression has a full response to naloxone. They may need a few minutes of oxygen or ventilatory support while the naloxone kicks in, but then they're awake, talking to you, and usually oriented. Then halfway to the hospital, they get sleepy and their respiratory rate drops. These patients are the ones who will need another dose of naloxone. Be prepared before giving the second dose, because it may cause withdrawal. The criteria to give a second dose is the same as the first. You suspect opiate overdose and have decreased respiratory rate or effort. Myotic pupils, pinpoint pupils, will also often be present. For patients who took a short-acting opiate only, this includes most IV opiates, and are fully reversed with naloxone, you should encourage hospital transport. If they can pass your competency evaluation, however, it is low risk for them to refuse transport. They have a risk of death similar to any other substance user on any other given day if they are competent to make that decision. There's a ton of research to support you on this point. However, it is your service's policy that if you gave the naloxone, you will transport that patient to the ER. So this might only be important to know if somebody else gave the naloxone, like a law enforcement officer or a bystander. We created a list of local treatment resources, which we will upload to the master and put copies into your clipboard in the ambulances. I would give any patients refusing transport who you did not administer naloxone to the list of treatment resources. Of course, document that you educated them on the risks of refusal, on where to seek additional help, their stable vital signs, and their competency to refuse in that situation. Also, make sure you've ruled out that this is a suicide attempt if the patient is refusing transport. For patients who took long-acting oral formulations like methadone and MS-Contin, these patients are at higher risk for rebound respiratory depression. Remember, anything that ends in contin is long-acting. In patients with partial or slow response, you may have only reversed one of the processes that are impacting the patient. These patients will likely not be competent to refuse transport, and they should go into the hospital. Remember, multifactorial overdoses are more common than isolated opiate overdoses. These patients may end up requiring additional naloxone or other interventions to stabilize them. So you'll not always be able to get this information based on the situation, but it's a bonus for a patient who cannot give a reliable history to the ER provider. If you can bring the bottles, they are always helpful. If you can get information on the time, route, and quantity the patient took, that is also helpful. If a bystander or a law enforcement officer administered any naloxone before you got there, get as much information as possible, including bringing the empty vial with you and asking about the administration time. As always, get any history you can, but cardiovascular disease, chronic illness, allergies, and the medications that the patient takes are the most important things. Thank you for listening. That concludes the naloxone education. Here are my references. If you're interested, they are easier to see on the protocols that you have in front of you or attached to this email. Next, we're going to talk about the project that we're piloting here in Three Forks, the multi-dose naloxone protocol. So, Three Forks Area Ambulance will be piloting an evidence-based multi-dose naloxone protocol that EMTs can use that was created specifically to meet the needs of the service with the input of your naloxone champions. To support the protocol, you're going through this training today. You're getting a badge card to help you remember the key factors to help you recognize and treat opioid overdose. At the suggestion of our naloxone champions, we put together a list of local and national resources for opiate use disorder treatment that you can use with your patients. So why would we do this? Well, first, your state protocols only allow 1 dose of intranasal naloxone. This is probably because intranasal naloxone is a newer medication, and the dose ceiling on it is quite different, as we've discussed, because of the bioavailability difference between intranasal naloxone and IV or IM naloxone. And protocols are important to protect your license. Quite frankly, I want this protocol to be there to support you and your practice and allow you to give the care you need and have legal support covering all of you. This protocol is based on a scoping literature review and contains evidence-based care recommendations. Second, as you all know, your transport times are long. 30% of patients who respond to naloxone require a second dose by the hour mark. Patients in urban areas would be in the ER by then, but your patients may still be with you in the back of the ambulance. Because the protocol allows you to give another dose of naloxone without stopping to meet up with paramedics, your patients get to the ER faster. Lastly, if Three Forks Area Ambulance Service develops a successful protocol that is supported by data that we collect here, it may be expanded to the state or county level. If that happens, it will be because of your hard work. So we will pilot the protocol here for at least 6 weeks. The goal at the end of the pilot period is to use the protocol in 75% of patients with opioid overdose. Administer naloxone to 60% of patients with evidence-based signs and symptoms of opioid overdose, and accurately document naloxone response for 75% of patients that we administer naloxone to. Reaching these goals would show that your service's EMTs and AEMTs exceed the national average at identifying and treating patients with opioid overdose. Further, it shows that you understand naloxone response well. Understanding that response is critical to proving you know when to give additional naloxone doses if needed. Ultimately, the goal is for all patients with opioid overdose and a pulse on an EMT initial assessment to survive to the ER or until they no longer need our care. So as an EMT, continue to document your patient care well. including naloxone administration, indications, patient response, additional doses, just like you normally would. The only addition for you is a sheet where I'm asking you to log every call. It will look like this, and it will be posted in the office. All the sheet requires is the incident number, so we can look up the report if needed. You can put the date and time on there if you don't have the incident number. If you use the opiate overdose protocol, if you decided to give naloxone, and why. And the primary reason for the sheet is that I cannot read all your minds. Your documentation will tell me when and why you decided to give naloxone, but not when you thought about it and decided not to give it. The sheet captures your thinking when you considered naloxone but did not give it. This proves your skill as emergency care providers. If you have a call where it was not applicable at all, such as a lift assist call, just put NA. But if you even considered opiate overdose and ruled it out, the answer is yes, and please answer the rest of the questions. There's not very many of them. There's also a box where you can give comments or feedback. If there's not enough space, send an email, put a note in Colleen's box, or text me or Colleen. My phone number is on the sheet. Some examples of when you might think about giving naloxone and decide yes or no would be a cardiac arrest situation. Might be a patient who is a COPDer, but maybe they have some pain medicine that they take sometimes, and they're sleepy and altered. But you decide that they're breathing 20 breaths per minute and you decide not to give naloxone. That would be a good example as well. If you have questions about the protocol, reach out to Garrett and Michelle, your naloxone champions, or me and Colleen. Again, my phone number is on the form and you'll have my email at the end of this presentation. And yes, if you don't have the incident number, just put the date and time. So what's next? Well, we'll start our implementation. Once we have EMTs trained, we'll send out an email to let everybody know what day we're starting. Okay. We'll run through January and maybe a little longer. Looking at the calls and the protocol use sheet about every 2 weeks. We'll make changes as needed based on your feedback and data from your patient calls, and then decide if the protocol works in March. If the protocol is successful, we will keep it and put a process in place to ensure it's integrated into annual training and onboarding. Also, the protocol will be submitted to your medical director for county-wide consideration, published in the form of my DNP project, and submitted to the State Board of Medical Examiners for consideration as part of any new statewide protocols. Thank you all. Your participation in this really matters. So thank you for being willing to do this and for being welcoming to me and this project. If you guys have any questions, my email is on the screen. My cell phone number is on the protocol use sheet. And feel free to text or email me at any time.